Hi, Dr.
Hello,
Vasuki.
Jason. How
Hello.
are you?
Yeah, I'm fine.
Merry Christmas to everyone, to all the attendees, and to you, and to everyone.
Thank you. And I think I also want to say Happy New Year because it's very closing to
Yes,
2024. Yeah, I wish everyone will have a good start of 2024. Yeah. So we still have 1 minute.
yes,
Yes, we can wait for more
let's
people.
wait.
Yeah. And while we're reading, I want to say thank you for all the attendees for supporting. I know it's during holidays, so maybe most of you spend your precious time to attend our webinars. And I also want to share our plan of uh, next year. In next year, in 2024, we will have more webinar and cases will coming soon. So hope you will like it. You will you can receive this information from the social media like Facebook, Instagram, from YouTube, from LinkedIn. So don't forget to subscribe us to receive the latest information.
Yes, next year we're going to have an amazing program with more people speaking, more experts sharing opinions, which is amazing. This is going to be a platform of sharing experiences and knowledge and also discussing cases at some point. You can leave your messages in the chat box or in emails, and we will be able to answer everything about techniques, about new methods that you want to try, about equipment, everything related to endoscopy. We're very passionate about what we're doing. Me in the clinical aspect, and Aohua from the supporting us every step of the way in the equipment aspect as well.
Yes. And if you have some questions about this webinar, during the webinar, you can just put it in the Q&A box. So Dr. Vasiliki will answer it. Uh, and we also want to have more interact with us. No.
Definitely. And if it's not in the domain that I master, because I do not know everything, if it's, for example, in laparoscopic procedures that I do not normally perform because I'm in internal medicine, we will definitely address to the right people in order to get your answers. So you can ask anything related endoscopy, and we will provide the answers from the experts' opinions.
Yes. And I've give the host to you, so maybe you can start it.
Okay.
Mm-hmm.
Let me share screen.
Yeah.
We're going to take it from where we left it last time, but we're going to, you can see my screen, correct?
Yes, we can see it.
Great, great. But we're going to talk more about interventional endoscopic procedures, and we're going to clarify today some diseases like lymphoplasmacytic rhinitis, for example, that is very, very commonly encountered. So what we have said last time, we have described all the equipment, we have described the anatomy of the nose, we have described also the patient preparation and all the preliminary workup that has to be performed, and the patient positioning. And now we're going to go into a bit more depth into the procedure, how the procedure is made per se. So we have shown this, but we will take it step by step, the procedure. As you can see, the patient is in sternal recumbency, and what we do is that we always pat the caudal pharynx with gauze swabs. Some people choose to put other swamps as well in the pharynx. I find ghost swamps very, very easy to use. In order to protect the larynx, because the whole procedure is done with flushing water, so we don't want huge amounts of water to be driven into the larynx. And if you have a water pump, then you do not have to worry on where to put your saline, as we said last time. If you don't have a water pump and you need the gravity to actually drive your the force of the water, then you have at least to put it high up, 70 centimeters and higher than your patient, and attach the saline bag to the import of your scope with a giving set. Then open the top of the giving set, and the fluid will be controlled only by the handles, by the endoscope stopcocks. You're not going to control the fluid from the saline, only from your stopcocks on the endoscope, because this is easier for you to do. So always mouth guards. Sometimes we have to put 2 mouth guards to open the mouth of the dogs. Always be careful about the use of mouth guards in cats, because this might cause blindness post-anesthetically. Okay, if the mouth is wide open in a cat, more than it should. We have to ensure that there's space for fluid to flow around the soft palate, because we want the water to get out of the mouth. Okay, and of course, always ensure that you have a very, very well-sealed ET tube cuff. Endotracheal tube inflated cuff. Okay, so we lift the cartilage, as you see, the alar cartilage, and we insert the scope into a ventromedial direction, not straight, but in a ventromedial direction. And then we grasp the insertion tube with the thumb. It's easier if I could show you this, but this is the positioning of the fingers. And most of the times I use I grasp the insertion tube with the thumb in the forefinger, and then rest remaining fingers, I put them on the nose of the animal, so that I can have more, so that I can attain more stability, because you need stability. You don't want the head of the animal to be moving right and left or back and forth. Always maintain the camera in an upright position, and the new cameras of Aohua, for example, in OR100, they have a spot that actually guides you if the camera is in upright position or not, so that you can correct your position and not be disoriented. And the actual flow of examination is, we examine the dorsal, the middle, the common, and the ventral meaty. And of course, there will be places that you cannot reach or that you cannot see. But this is why we priorly perform a CT scan, so that we go into rhinoscopy guided. The ventral meatus always reaches the choana and the nasopharynx, and in order for you to have a full rhinoscopic examination, we should always reach the choana and the nasopharynx from orthograde, not only retrograde. Okay. And let's see, a lot of people ask me, how is it, why don't we do, for example, rhinoscopy, orthograde rhinoscopy with a flexible scope? I rarely perform with a flexible scope because we have a lot of hemorrhages. The nasal cavity has a lot of vessels, so it's it has a lot of blood, and doing a procedure without flushing water will only lead at some point to hemorrhage. So we definitely need a rigid scope. Having said that, I'm going to show you orthograde with flexible scope, but it's very limited. So this is the nasal turbinates, and we can see, as you remember, the nasal turbinates have are much more apart one from the other. And we're going after that into the ethmoid turbinates as well. So you see that flexible scopes, yes, they do have a good image, yet, and we can see some mucus here at this point. I don't know if you can see my sensor. But the image is getting blurred by a lot of mucus, and if you bleed at some point in patients that are not normal and that have maybe problems in their coagulation, or maybe due to the increased vascularity of the nasal conchae, we have a bleeding at some point, then it's very, very difficult to clear your image and your picture. And either way, even if you do it with a flexible scope, or if you do it with a rigid scope, you will always lead up to the choana. Okay. So you see that we have a lot of blurring in the flexible scopes doing endoscopy. Very good image. The rigids, though, have a better image in the orthograde rhinoscopy. We see a bit of mucus, which is transparent, and it's only normal to be in the nose. This is the septum on the right side of your picture, as you see, and the turbinates on your left side, as you can see it. And we have to be very, very careful and try not to do a lot of manipulations during our rhinoscopic procedures with the flexible, because we don't want, as we said, bleeding. And here you will see that I will reach up to the choana. We see a bit of hyperemia, but that's pretty much, you know, the normal nasal mucosa, the color of the normal nasal mucosa. In some of my rhinoscopies, you will see that the nasal mucosa is whitish or even grayish. So here we go into the choana, we go back to the nasopharynx, and you see that it's depicted as a tube. The nasopharynx is depicted as a tube, and we have the eustachian openings here for the ears as well. And you can see my endotracheal tube as well. Okay. If you have any questions or you want to discuss something about it, and let's see the image of the rigid scope in orthograde rhinoscopy, which is the gold standard. You see that we can flush water, so even if it bleeds, it will not obscure our image. And the other advantage that we have with the rigid scopes is that we can have a rotation of 360 degrees in order to actually see peripherally what the lesions are. And you see that even if it bleeds, it doesn't show that much. So we have a much better view. And this is a normal, again, mucosa. So I was saying that in some of my rhinoscopies, you might see that the mucosa is a bit whitish, more whitish. And this is because prior to the rhinoscopy, sometimes we put an agent for vasoconstriction like Vibrocil, diphenhydramine. Okay, so sometimes we have this color due to vasoconstriction. So the procedure with aggressive flow of water, we use mostly water that's room temperature. We try it not to be very cold, because we have the advantage from the cold water that yes, it will actually stop the bleeding, but it will reduce the hemorrhages. But we might have hypothermia because these procedures might last for 30 minutes to 45 minutes. You can also use old saline bags that we cut, the roof, and we can put just normal water. We don't need sterile normal salines for their rhinoscopy procedures. So you can reduce your cost doing that. You should always be very cautious and avoid rapid movements in order not to cause trauma. And once you get in, you do not do right and left movements, abrupt movements. If you want to examine an area, then you take the handle of your light source and you can rotate it so that you can have a very good peripheral vision. And always keep in mind that your scopes, the scopes that you use for rhinoscopy, have a 30 degrees angulation. So we always have to keep the lumen at the bottom of the screen. And for this reason, Aohua has actually put the spot so that we know that we have the camera in the upright position. We always have to align our scope with the nasal septum, and we examine the rostral nares first, and then we go to the nasal conchae and then the ethmoid conchae. The common meatus immediately between the nasal septum and the ventral meatus, and it's the easiest way to follow. Even if you close your eyes, you will go to the common meatus. And common and the ventral meatus leads to nasopharynx. Please beware when you're in the dorsal meatus and you reach up to the conchae of the eye, the ophthalmic conchae. Don't push very hard, and don't biopsy the brain, because after that spot here, you go into the brain. We go into the ventral, the medium, and then the dorsal meatus, so that the bleeding always stays ventrally to the meatus examined. So we don't go randomly. Always in scoping, there is a certain plan that we go, and our plan is to always keep our image unobscured. And in order to have a clear image, we have to go first ventrally, then medium, and then dorsally, so that all the bleeding goes down from the meatus examined, okay? And always, when we have a problem, we don't go to the pathological side. We always examine the normal side first. And let's go step by step. So we said that we start with the rostral nares, and the nostril nasal cavity has the turbinates in the nostril nasal cavity are not well formed. They're not well developed. So we have very few turbinates in this area. And of course, you say that, why do I care about this information? Because once I get in, then I know that I'm very, very proximal to the nasal planum. But you do need to know the anatomy, because at some point, maybe one of your residents or one of your assistants will perform rhinoscopy, and you definitely need to know how to interpret the video, or even you yourself. 5 months, 6 months after a rhinoscopy, you might revisit your endoscopic procedure, and you should know where you are anatomically, okay? So in this area, the pigmentation that you see here is normal. We might have black pigmentation, like the one that I'm showing you. And at the end of the rostral nasal cavity, we have the branching of the ventral nasal. This is the branching here in the last picture. Branching of the ventral nasal conchae seen from the middle meatus. And here you see the positioning of the animal and what we see in the rostral nasal cavity. Let's go a bit further back now. So we're going step by step back. we are still in the nasal turbinates, okay, and we have smooth turbinates in the rostral nasal cavity, and as you see, the space between them allows a lot of air movement, because as we go further back, especially in cats, the ethmoidal cavities do not leave that much space for air. And we have to have some landmarks. And our landmark is the nasal septum, as you see on your left in this picture. Okay, it's smooth and flat. Okay, and it has to be, you see here that it's a bit more whitish than in reality. It has vascularity, especially as we're going rostrally towards the nasal canal. The vascularity that we see increases. Okay. And sometimes we can see the openings of the nasal lacrimal ducts. Sometimes not. It's not very easy to detect them. Okay. And then we proceed to the ethmoid turbinates, and we are certain of this transition because the anatomy and the picture that we get is totally different than the nasal turbinates. The ethmoidal turbinates have this crumpled appearance, more thickened, the folds are more thickened than the nasal turbinates, and also the interspace between these folds is much, much smaller, okay, as you can see here. So they don't allow a lot of air. And this is the way going to the ethmoidal turbinates. And the last section is the nasopharynx. Okay, the nasopharynx is either entered ventrally or medially, as we said, and the appearance of the nasopharynx is like a cylindrical, a circular tube. As here, we can definitely see the opening of the Eustachian tubes at the junction of the lateral and dorsal walls, and I'm going to show it to you here. They are as well. Okay, and this is pretty much our first path towards the our first rhinoscopy path that has to be accomplished up to the end. There are certain limitations of not accomplishing a rhinoscopy path like that, and this is only the obstructive diseases out of tumors, for example, or a foreign body, or whatever might actually obstruct the flow of this path. In any other case, we should definitely go ahead and accomplish the full rhinoscopic procedures up until we reach the choana. So at the end of every procedure, lower the tip of the nose and lower the head of the animal, because we don't want all the blood and mucus and retropharyngeal discharge to go back to the larynx. Keep the sedation. Don't have the animal waking up abruptly, but keep the sedation if you have profuse hemorrhage. And in general, try to waken the animal gradually, not abruptly. Extubate the last minute, you know, when you see that the animal starts coughing and have reflexes. Allow a very quiet and slow recovery, not in the hospitalization area with all the other dogs and cats barking at this poor animal, because we might increase the bleeding as well. If you have a profound hemorrhage, then you might use ACP not only beforehand, but also after your procedure. And please do not forget to take out the gauzes, because this is, you know, sometimes I do forget it. And the last minute, you know, we have to take the gauzes out. It's only human. So please do not forget to take the gauzes out once you have accomplished the whole procedure. And also, if you have profound hemorrhage, you can also flush the nose with a gauze pack of adrenaline, okay, 1 to 10,000. And as we said, don't forget the packs. I should, highlight it and highlight it again. And what about retrograde rhinoscopy? Retrograde rhinoscopy is where we use the flexible scopes. This is the gold standard for, the flexible scope is the gold standard for retrograde rhinoscopy. I know that a lot of companies have some rigid scopes that can only do, you put them from the mouth and they have a 270 degrees angle scoping of scope so that you can see the nasopharynx once you put the rigid scope through the mouth. But there's not much to do because you cannot intervene, you cannot take biopsies, you just see the pharynx. And to be honest, I didn't find it quite handy. So I use mostly for retrograde rhinoscopy the flexible scopes, and we definitely do it under general anesthesia and sometimes under local anesthetic as well, maybe xylocaine, but general anesthesia is fine. If the patient, because this is a very, very sensitive area, I'm sorry about the barkings, but I'm in the clinic right now. This is a very sensitive area, so we have to increase the general anesthesia if the patient starts retching, and they do it like that. And in this area, we have increased vascularity and bleeding. Once you try it the first time, then you will not be able to try it a second, third, or a fourth time, multiple times. So you have to, be able to do it, the first or second attempt. Otherwise, you're going to have a lot of bleeding. And as we said, with flexible scopes, we cannot have bleeding, and we cannot obscure our image with bleeding. So we're gonna have, okay, just give me a second and I will take care of the barking. Okay, I think we're good. Definitely a cuffed ET tube, pharyngeal packing again, and we insert the scope orally. Sometimes there are two ways of inserting the scope. The first way is try it outside the patient and see how it is retroflexed, so that we know the angulation, and then we insert it straight and we can retroflex it in the patient. And the second way is to retroflex it and push it retroflex, which is a bit dangerous for your scope. So I would rather do the first technique, try it outside the patient, see the angulation, and then make it straight, and then go and retroflex it in the oropharynx. We have to move, when you're already retroflexed, when you move the tip of the scope near to the nares, the scope viewing is taking away, so it goes back. This is a bit paradoxical. So the more you take out the scope, the closer it gets to the choana, the more you push your scope towards the nares, the more the view is getting bigger. The diameter of your image is getting bigger. Let's have a look. So you see here how it is done, sternal positioning. This is the view that we're having. This is the dorsally, this is the soft palate. And then we have the two nasal choana, okay? And the pharyngeal, this is the pharyngeal mucosa. And let's go and have a look. So I tried it outside my patient, okay? And you've seen these protrusions, which were the Eustachian tubes. This is a very, very nice picture. Here it is symmetrical. no nasal discharge, no masses, and this is pretty much normal. Increased vascularity, you see how prominent the vessels are. Okay, let's have a look at that one as well. Oh. You can see here that in this patient, we have these nodules, which are normal. And this is the openings of the Eustachian tubes. Okay. And there was also a nodule in the middle, if you've noticed, which is of no clinical, relevance. And this is our only attempt. We don't have many attempts in that. Otherwise, it will bleed, as we said. Okay. Let's see what happens if we have neoplastic or other kind of obstruction. This is a very old scope. A small one with a very small diameter. This is why the view is not that good. With the new Aohua scopes now, we have amazing view. So you can see that we have this obstruction by mass tissue. Okay, and you can even take biopsies retrograde this way, and because sometimes orthograde, you're not able to reach this point to take biopsies. And if you want to take biopsies on a retrograde position, you first have to put your forceps in, just as we do in the J maneuver in the fundus of the stomach, then straighten your scope, and then retroflex in the oropharynx and take out your forceps. Otherwise, you will ruin your scope. Okay. And another obstruction from tissue mass, of course, we knew that because we have already performed our CT scan. And you see that it's totally obstructed. Increased vascularity. And this is how we take our biopsy samples. I had pre-filled my forceps, okay? And then straightened on a straight scope. And then with my forceps in, I went in the oropharynx, retroflexed, and take out very, very cautiously my forceps. And this is actually very, very, it's an amazing way of taking biopsies, which are really representative. Okay. Now you see all the environment. Okay. And let's see what happens when we have retropharyngeal hemorrhage. We have a lot of animals actually come with melena, and you ask the owners, do they vomit blood, for example, and they might as well vomit blood, but you go into the stomach and there's no ulcers. You go into the duodenum and there's no ulcers. And where the blood comes from, because sometimes they do not take it out from the nose, they do not sneeze. If it's very, very caudally, the disease, they just swallow blood. So this was coming from one choana in the nasopharynx, as you see. And you can actually locate the problem this way as well. You know which is the pathological nair. So always keep that in mind in animals that come with a clinical history of vomiting blood. Always check if the blood is coming from the airways or from the retropharyngeal section. And we already said how we're taking our biopsies. So we have to, if we want to take our biopsies orthograde, then sometimes we need bigger biopsies, chunks, what we can do is pre-measure with our forceps and put a mark on our forceps, because we might as well, you know, biopsy the brain, and if we do not want to go further the medial canthus. Okay, and we can go even blindly. If we have a pre-measured biopsy forceps, we can go blindly, and with a bigger forceps that we use, for example, for our gastric biopsies, or even short biopsy forceps that have bigger openings, bigger capsules, so that we can take more representative biopsies, but always pre-measure. Okay, you can take them either blindly or under the guidance of your scope on the side, alongside, putting them alongside your scope. This dog will never give up. Okay, let's see on an orthograde rhinoscopy how we can take the biopsy. You can see here that we're going, we can see a bit of a mucus. And this is the biopsy through the scope, not alongside the scope. The turbinates. And for the biopsies through the scope, we have smaller biopsy forceps that can actually go through our working channel. But when you take your biopsy out, you don't take it through the channel, the working channel, you take the whole scope out, okay? Not just your biopsy forceps. Because in the nose, we can take big chunks of biopsies, but if you put them through squeeze them through the working channel, you will leave half of your biopsy either in the nose, in the nasal cavity, or in the working channel of your scope. So at some point here, I'm trying to, what do I do? Why do I take the time? Because I'm trying to see what is the perfect location for most representative biopsies. And you will always try to go to the ethmoid cohort or wherever the pathology is in order to take your biopsies. And always under vision, because at some point you might lose your biopsy forceps, and it might be led to, you always have to have this view of your forceps, and especially when you go alongside the scope and you go with your under endoscopic guidance, you should always watch where your biopsy forceps is, because sometimes it might go to the medial canthus, or it might be your biopsy forceps might be in a degree that is not visible, and you might lose your forceps, the view of your forceps there, okay, and do damage. So as you saw, we took all the scope out with our biopsy. And we have to have very good opening of our biopsy forceps in order to get good biopsy. You have to navigate your scope in such an angulation so that the cups of the forceps open widely. And let's see another retrograde biopsy with a flexible scope. You see here that we have unilateral mucopurulent discharge here as we see it in the right nostril, which is the left actually. And as we said, the technique is that we go and straighten, put the forceps, and then retroflex. Okay. And you can take cultures, deep cultures from here with a brush as well, brush cytology. And let's see a unilateral retrograde mucopurulent discharge, sometimes the discharge is much more retrograde than it's orthograde. So some animals lick the nasal discharge, so the owners or even the vet cannot perceive the extent or the amount of the nasal discharge. And if you go retrograde with a retrograde rhinoscopy, then you can see it, okay? And here we can see that it's on, as we see the picture here, you see how easy it bleeds because this is a chronic rhinitis, and the tissue is very friable, so it bleeds easily and the picture can be obscured. And most of the pathology is on the left side as we see the picture here, which is on the right side of the animal. Any instrument that we pass through our flexible scope will be with the same procedure. So you can see here the brush that's taken out, and we're going to go and have some brush cytology, and it has to be traumatic. It has to be really, really traumatic, our brush cytology, and on the surface of the mucosa with a very good attachment to the surface of the mucosa. Okay. This, by the way, might cause gagging and stretching. So you have to increase the general anesthesia when you're doing this with a brush. Let's watch the other one as well. So this brush could be sterile, and we can just cut it and send it off for, culture. Or with one brush, we can do culture, and with the other brush, we can do cytology as well. You saw how traumatic it was. It bled a lot, as if we were taking biopsies. And these are more representative cytology samples. And let's see how unilateral mucopurulent discharge is seen orthograde from the front. It's much easier to see it retrograde. You will see that at some point I will reach the nasal choana orthograde on an orthograde procedure. But during this endoscopy path, the nasal discharge will not be too much. You can see some nasal discharge here, yes, which is mucopurulent, but it's not the amount that we see in the nasopharynx. And the reason is also because the orthograde rhinoscopy is performed under flushing. So we flush all the mucosa more caudally into the nasopharynx. And once you see the tube and the vascularity, we've reached the nasopharynx, and you see how much of a nasal discharge has been stuck there. These are chronic rhinitis cases. Okay, what about foreign bodies? Which are the most common foreign bodies in the nose? The most common foreign bodies are grass awns, blades of grass, and sometimes, especially in cats, they can swallow grass and then they can vomit it, and it can go up to the nasopharynx. Okay, so always beware if you have a reverse sneezing. In some animals, check always the nasopharynx with retrograde rhinoscopy. Some conifer needles, very, very common here in Greece and in the Mediterranean. Sometimes pieces of bones in the same way through regurgitation. Tooth fragments as well, some metal fragments, and iatrogenic materials like orthopedic implants. And most commonly we have unilateral mucopurulent or purulent exudate. In more systemic diseases, like, for example, distemper virus, you can have bilateral purulent nasal discharge. Beware always, because we can have aspergillosis and fungal disease in places that we have an old fracture or a foreign body, especially grass bones. Okay, these are places where later on aspergillosis can be developed. And this is a very common one. Always try to take it out from the stem and not from the smaller parts of the grass own. It's not always very, very easy. And sometimes it's lost into pus and hemorrhage if it's not fresh. There could be a lot of blood and from the constant sneezing. And if it stays more than 1 week, 10 days, then you can also have pus, and it's not that easy to find the foreign body. And once you find the foreign body, don't say, okay, I'm done, because we have been in so many traps so many times that, you know, maybe this dog has a second and a third one. And this has happened to me more than once. Okay. And as you can see, we found it. We just found one tip of the grass. And sometimes you go and grab this one. And unfortunately, it breaks. And you have to go again and find the same location where in the nose, it's not that easy. You're not in the stomach where there's only one lumen. Okay, and you go out with the whole scope, not just with your forceps. Okay, not through your channel. Let's have a look. In different foreign body retrievals. Here, as you see the pigmentation, we were externally. We were really, really next to the nasal plan. And there's a lot of blood and blood clots because the dog was sneezing all the time. And this was 24 hours after. And sometimes, you know, the referring vet has already tried with an otoscope to remove the grass own and was not successful. And I do not know, and please don't do it, why people do not sedate animals in order to take grass owns from the nose. There has to be sedation. I mean, even general anesthesia with propofol. Do not use just light sedation where the animal can move. Use propofol in order to inspect the nose correctly and in order not to cause more trauma. And as you see here, the foreign body, we were very lucky. It's inside a clot. And I had another video with 3 or 4 grass owns that we were taking out, and we were saying, okay, that's the last one. And then again, there was another one. And then we said, okay, that's the last one. And then again, there was another one. So you have to inspect twice in both nostrils as well. And sometimes it's very, very, it's in the ethmoid turbinates. And as we said, in the ethmoid turbinates, there's not much space in between. And the foreign bodies there can really cause a huge, it can be a struggle to find them, first of all. And secondly, can cause much, much more pus and mucopurulent discharge due to the location, because it's not easy to find them. It's not easy to wash them out. So we have to be guided by the irritation. If we don't know where the foreign body is, we have to be guided by the irritation, by the hyperemia of the mucosa, by the mucus that we see inside the nostril. Okay, this is an easy way to guide yourself towards where to go. This is mucus, as you see here. And we're suspecting that the foreign body should be maybe behind the mucus, and we can see a small thread of the grass own here as well. And sometimes this is the only thing that you will be able to see. You see here, this is it. Covered in mucus. Sometimes it's even worse. It's covered in pus and mucus and you're not able to see anything. So I'm staying there. I'm flushing all the time so that the mucus will reveal my foreign body. And I only have this opportunity to take it out. Otherwise, I will cause huge bleeding. It will obscure my image. As you already see, it caused bleeding. If I haven't grabbed it, it's going to be very difficult to get inside again and take it out. And let's talk a bit about nasopharyngeal stenosis. I don't know how often you see that in cats mostly, but also in dogs nowadays. I've seen a couple of cases. It could be congenital or acquired, especially in cats with upper respiratory syndrome. These cats are in a dreadful position. And last time in the first part, I have shown you two of the cats that I treated with the symptoms that they had: open mouth breathing. They couldn't breathe. They were regurgitating. So the symptoms are stertorous nasal breathing, dyspnea, open mouth breathing, gagging, repeated swallowing and sneezing, and chronic serous or mucopurulent nasal discharge. These animals are not able to eat. They lose weight. And what we should do, first of all, is a retrograde rhinoscopy in order to diagnose it, and then to cure it with either balloon dilation or stent placement, and I will show you. Surgical resection sometimes, but please beware not to cut the soft palate too short. Because we have chronic rhinitis, we have all the food is going into the nasal concha after that. Laser ablation sometimes. Sometimes there's pure atresia. There's not even a small hole into where to guide your balloon. And what we do in these cases, I will go through step by step, but in dog, in order to let you know what we do. So this is with the monitor of the scope and with the monitor of the CR fluoroscopy in order to help us with the balloon dilation. You can do it with only the help of your scope, with a vision of your scope as well, just for the sake of educating ourselves. So you go into with the flexible scope and you retroflex it in the nasopharynx. And this is probably the only time that I will put the brakes on my scope so that it stays retroflexed. And I always have a vision of the nasopharynx. Okay. Then a guide wire, as you see here, is passed through the working channel of your scope and through the stenotic opening under endoscopic vision. You always have to have endoscopic vision. If there is no opening, because sometimes you go there and there is no opening, there's just a wall. You either have to puncture it and create an opening, or it has to go surgically. You have to go surgically. Okay. And then the guide wire is passed then rostrally. So you go into and through the endoscope working channel and you pass the guide wire and then you take it from the front. There's another technique that you can push the guide wire caudally, orthograde, and you can see it with your scope coming out of the nasopharynx. Either two techniques, both of the techniques are correct. Okay. And then An esophageal balloon dilation is placed over the guide wire, okay, and it passes through the nostril and the ventral meatus into the nasopharynx. And we know, because we have the C-arm, and even if you don't have the C-arm, you can have it under endoscopic vision. You see your balloon. You can see it here. This is the placement of the patient. And this is after the opening of the balloon. Let me go a bit here. And I want to show you. You have to place the balloon within the stenosis, just as we do in the esophageal stenosis strictures. And you keep it there for at least 30 seconds up until it bleeds, and it has to create a big dilation. And after that, after you have created the dilation, you can also, the procedure is repeated just as in the esophageal strictures, maybe multiple times, and you can put a stent, but in order to put a stent, you definitely have to do the balloon dilation first. And the stent can also be placed over the guide wire that you have initially placed from the beginning. You take out the balloon, you put in the stent in the same guide wire. Let me show you another thing here. What kind of balloons? First of all, the guide wires are here, 160. If any of you have done the procedure, please let me know and we can have a discussion over your questions here. The guide wire that I use is this one, 160 centimeter of length. And the balloons, it depends. We can use balloons, as we've said here. Let me go back a bit further back in the presentation for somebody who was not here in the first part. The balloons are around 11 millimeters for cats, 8 to 11 millimeters. These are the balloons. So the balloons ranges from 6 to 18, medium 9 millimeter in cats and 11 millimeter in dogs. Okay, and the stents from 8 millimeters to 14 millimeters for the nasopharynx, for those of you who missed the first part, so that you can have it. Let's go back. Any questions on the balloon dilations? I know that some people do it, totally blindly. They just put the balloon in and they just have the flexible scope retroflexed and they do the dilation. Sometimes it's not that easy because you just have a wall. There's no opening. If you have any questions, put them in the chat box because it's a very, very easy procedure. It needs to be repeated. And especially if your cat is positive in calicivirus, then it's going to be an ongoing process. I hope it helped, the step-by-step approach. And of course, we can have nasal neoplasia. And sometimes it's not that easy to detect which tissue is pathological and which tissue is not in the nasal cavity. Sometimes the neoplastic tissue is more whitish in color. Sometimes it's overpigmented. It has a different texture, consistency, and color from the normal tissue. The benign neoplastic diseases are polyps, chondromas, and osteomas, and the malignant adenocarcinoma, nasal adenocarcinoma is very, very common. Osteosarcomas and chondrosarcomas as well. So we're looking, you see that there's a destruction of the normal turbinates tissue here. And we're trying to find, this is why we should always be guided by our CT scan. You see that there's a different kind of, there's a mass lesion there, different in the texture of the normal, from the normal mucosa. And this is where we go, because I've heard a lot of times that you go into having your rhinoscopy procedure and you take normal nasal tissue that's a bit, you know, troubled due to the inflammation, but you don't take the neoplastic tissue for biopsies. Let's have another one. Oops, sorry. This is not playing. Let's try something else. No. This is not working. I'm sorry for the second video. I will find another one with neoplastic lesions. And this is a chondrosarcoma in an 11-year-old golden retriever, and we did laser ablation. You try to take out as much tissue, neoplastic tissue as you can. It's palliative anyways. It's not something, it's not to be cured, but it really unobstructs the breathing pattern, as we said in part 1. And from those of you who want part 1, because we have commented all the instrumentation needed, you might send an email to Aohua and they will send the link to you. We normally use a 600 laser, micro laser, the laser beam, but a 400 could also work. And another entity is nasopharyngeal polyps. It's very easy to detect them, even if you go with your, you know, with a forceps and you just take out the soft palate. They protrude sometimes. They are non-neoplastic masses. They arise from the auditory tube or the middle ear, and they grow into the nasopharynx, into the external ear canal, or both. Mostly we see these masses in young cats from even 6 months old. We've seen very, very young kittens having polyps, benign polyps. Is it congenital? We don't know. Some people think that they derive from the brachial arch remnants. Could it be due to viral infection? We have isolated calicivirus from one report, from polyps in one report. They've repeated this test in other polyps. They've never found any other viral component in any other polyps. So there's only one report. And there's a species cycle. Is the polyp derived from the inflammation, or does the inflammation triggers the formation of the polyps? So it's the otitis media, inflammation, formation of polyps, and then the formation of polyps keeps making the inflammation even bigger. In dogs, we have only one report in a 7-month-old Chinese Shar-Pei. Most of the times we have noisy respiration, just as in the nasopharyngeal stenosis, nasal discharge, dysphagia. Some of these animals regurgitate, come with regurgitation. And we have uploaded an amazing case of a tonsillar polyp in the YouTube for those of you who want to visit it and see it. Where the CT scan was saying that it was an esophageal mass, where it was a tonsillar polyp. Okay. If the polyp is in the ear, we can have head shaking, we can have ear scratching, head tilt, and some of these animals lose their balance as well. It's very easy to remove these polyps, the nasopharyngeal ones. I'm not talking about the ear now. By grasping either the stalk or the body of the polyps and gentle increase the traction. Sometimes we do, you know, circular movements in order to take the polyp out. There's not massive bleeding, so no stitches are needed, especially in cats. And sometimes if they're very, very small, some surgeons split the soft palate. I would rather not split the soft palate. Okay, and this is the views that we have in the CT scans, and this is a very, very huge nasopharyngeal polyp that caused actually megaesophagus in a 6-month-old cat. And what about fungal rhinitis? I know that in some countries, this is a huge issue. To be honest, I haven't encountered that many cases, a heavy caseload. I don't know if you have. Please leave a comment in the chat box if you have encountered aspergillosis and fungal rhinitis cases. Mostly we see that in young to middle-aged dogs, 3 years old, 4 years old, young adult dogs. Labrador retrievers, German shepherds, dolichocephalic breeds. It's very rare in cats. The fungi that we might encounter is mostly Aspergillus fumigatus, some Penicillium and Cryptococcus, yes, but mostly aspergillosis. As we said before, at the sites of primary nasal tumors, foreign bodies, or old fractures, these are the places where aspergillosis could come as a secondary infection and could be developed. Some also think that it could be due to, in some animals that are immunocompromised because they have an impaired lymphocyte function, but it's not proven. Mucopurulent, what are the symptoms? Mucopurulent nasal discharge, where at the beginning it's unilateral, nasal pain and epistaxis as well, decreased appetites when the disease progresses, nasal depigmentation and ulceration, stridor, stridor, all these noises from the obstruction of the nasal cavity, open mouth breathing due to the heavy load of nasal discharge, facial deformity, epiphora if we have ocular involvement as well. Beware of the serology because we might have, you always have to encounter false negative results with septicism. Sometimes the disease is in early stages and the serology comes out negative. Okay. Always do imaging and a CT scan. Can we see the auditory tubes in cats with anterograde rhinoscopy? Is there a TEEB landmark? Thank you. We will talk about it. I will show you. And rhinoscopy, turbinate. In rhinoscopy, what we can see in, I'm going to finish with the fungal rhinitis, and we're going to come back to the Eustachian tubes in cats. Turbinate atrophy and mucopurulent discharge, and of course the fungal plaques, which are very, very representative. The fungal plaques may be greenish, may be white off in color, and sometimes they're fuzzy, and this is due to the appearance of the conioidiophores of the fungus. Okay, and of course, in these cases, the treatment with antifungals, with the common antifungals like ketoconazole or itraconazole is very disappointing. And this is why we go into the topical administration of clotrimazole or enilconazole. And this is a 7-year-old German Shepherd dog with mucopurulent nasal discharge for 7 months. And sometimes these animals, just priorly to the nasal discharge, they chew always on one side, but there has to be an owner that's very, very dedicated and very, 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 very meticulous in observing that this animal's chewing only on one side, okay? You see the fungal plaques here, this white off material that's stuck into the mucosa. And let's have a look of an endoscopy, an endoscopic procedure. And to be honest, this is the nasal conchae of a dog, and there are no nasal conchae here. Everything is like an empty tube. Everything is distorted and without any turbinates. All the turbinates are eaten up. And you can see it here as well. You can see the greenish material and whitish material as well. but the anatomy is distorted, as you see. Here as well. I don't know why some videos are not playing. You can see here that there are no turbinates. So what we do as a treatment is that we definitely have our ET tube, and we have to debride as many plaques as we can with suction, with biopsy forceps, with grasper, with bigger graspers, because if you leave the colonies of the plaques, the fungal plaques there, then the disease will recur. You will not do anything. Remove the throat pack, okay? Place a Foley catheter into the mouth, as you see, and we have to retroflex the Foley catheter here onto the soft palate. Inflate the bulb of the Foley to seal the pharynx. Some people use sponges as well. Definitely, we have to seal the whole area, and we put Foley catheters as well into each nostril. First, a urinary catheter, and then a Foley catheter alongside to each nostril in order to ensure good seal. And then we have to inflate, as we said, the bulb of the Foley catheter to seal the nares. Clamp all Foley catheters shut. Seal the leaks with cotton buds. Please do not make your dog, like a porcupine. This is not a good way to seal all the leaks, but please put buds in order to assure a good leak, a good seal, sorry. Fill 2 syringes of 60 ml each with 5% of anilconazole, okay? Instill 50 ml into each nostril in the urinary catheter slowly over 15 minutes, and then we rotate the angles of the animals and repeat for 15 minutes and rotate up until we reach sternal recumbency. This is a case from Philippe Lermet. Beware, because anilconazole is irritant, and we have to lower the head after we finish, okay? So that we don't want it to, we want to drain anilconazole and not let it go to the interior nares. And we have to repeat this procedure 2 to 3 times. You see that we have ensured here closure of the catheters, sealing of the catheters, and we rotate the animal every 15 minutes to a different position so that the anilconazole goes to the whole nasal cavity. And to be honest, after the first procedure, some animals only do 1 procedure. It's 80 to 90% sufficient. And some animals require more procedures as well. And of course, when the problem is also in the frontal sinuses, it is not enough to treat with anilconazole just the nasal cavity, because the problem still exists, and you have to actually do a trephination to the frontal sinuses, and I'm showing you the site. In cats, it's a bit tricky because it's very, very thin and you can enter the brain. You can use either Michel's trephine or a Simon pin. And the trephination, as you see, is halfway between the dorsal midline and the zygomatic process of the frontal bone. In large breed dogs, it's easier. In small breed dogs, it's a bit more tricky. And of course, you will put the same solution in the frontal sinuses that we used in the nasal planum for at least 15 minutes and still really, really slow the anilconazole solution. And last but not least, we have the lymphoplasmacytic rhinitis. It's very common in dogs. It's a chronic gradually nasal disease associated with mild or moderate nasal discharge. And most of the times, the nasal discharge, to be honest, is mucus. It's not even mucopurulent. And we have dogs and cats that are periodically sneezing or snorting, and we take it as an allergic disease, maybe as an allergic underlying disease. So in humans, it has been proven that it could be related to inhaled allergens or irritants. Is it the same thing in dogs and cats? Could be. Dogs with lymphoplasmacytic rhinitis, it has been proven that they have higher IgM and IgG antibodies in the nasal secretions. And in dogs, it doesn't, in humans, it occurs concurrently with conjunctivitis or lower allergic disease, but in dogs, it has not been proven. And most dogs that have lymphoplasmacytic rhinitis only come with this symptom as a sole symptom and not combined with lower airway disease problem. Is it also an exposure to secondhand smoke? Pathetic smokers, you know, is it an immune, has it an immune mediated pathogenesis because it's responsive to corticosteroids as well? These are all hypotheses that have not been proven. We are certain that it's a non-infectious clinical symptom, but infections can trigger the disease, like in upper respiratory syndrome in cats. And during the rhinoscopy procedure, we have mild mucosal hyperemia, which is more marked in patients that have secondary bacterial disease as well. We have thickening of the nasal turbinates, and of course, increased friability and hemorrhages. And these animals respond very well in immunosuppressive dosages of corticosteroids that we taper in an anti-inflammatory doses afterwards. What I've found very, very handy are the steroid eye drops or the inhaled steroids that we can put in the nose. And they are very good to effect. And let's watch this one as well. And as you can see, we have serous, you know, mucus in the nasal cavity, hyperemia, but not, you know, something else. You see hyperemia, you see that the turbinates are a bit more thickened. And that's pretty much your findings there. You're not going to find anything else, and your definite final diagnosis will come with the biopsies. And it's very, very interesting. And, you know, at some point we should investigate that further, that these animals with lymphoplasmacytic rhinitis, some of them have also lymphoplasmacytic IBD. I don't know if it's linked or not. It has been my observation. And, you know, someone should investigate those as well. Thank you very much. Let's answer now about the Eustachian tubes in cats. It's the same landmark as in dogs as well, but they're not that protruding. You can find them retrograde. With retrograde rhinoscopy, if you have a very small flexible scope, you can watch them. And it's, let me show you how it's, hi, Babak, hi. Happy New Year to all my friends. Let me check and go back a bit with the Eustachian tubes in dogs. It's the same landmark, but it's much, much smaller. It's not that easy to discern. Orthograde, definitely not, but retrograde, you can see the openings, yes. And it's the same landmark as in dogs. Let me see if I can show you. You will have the video recording, and you will be able to see the landmarks. Let's see, maybe here. Just to show a bit. Here we're going to see, this is a dog, but you can see the openings right here that I'm showing. You can see the openings here and here. And this is the same landmark in cats, but you have to go a bit further back in order to see them. And they're not that protruding in cats. Okay, the opening is not that easy to discern. You can see them here, how easy it is to discern them. Okay. Thank you, Maria. Thank you, and Happy New Year to everyone. If there are any other questions, I'll be very happy to answer them now, or you can rewatch the material at your ease, and you can send me, you can email me or email Aohua with all the questions, and they will forward all the questions to me. Any other questions? Have you done rhinoscopy? Do you perform rhinoscopy? Does any of you does rhinoscopic procedure, and what do you do? What do you perform? Retrograde, orthograde? Okay, that's great. That's great. Once you get the landmarks and the anatomy, it's going to be very easy for you to perform. You just have to, have all the precautions set. Your pre-op, definitely blood work, and then proceed into the endoscopic procedure. Great. I see you all have rigid scopes. Have a flexible one as well. Not only rigids. Rigids are fine, are good, but they don't give all the solutions. Great. Thank you very much for the attendance. Happy New Year again. Thank you for enduring me 2 days before, the new year. But it was an amazing closure of the new year. Thank you all so much because some of you, I see you in all the webinars. Thank you so much for following Aohua and for following me in the webinars. And we will keep an open path of communication next year as well. Thank you, Jason.
Yeah, thank you, Dr. Vasilikhi, and I think we have very good cooperation this year, and I think next year it will be more crazy.
Yes, definitely. Next year,
Yeah.
we're going to have a lot of more amazing stuff next year.
Yes.
We're going to have a lot of guests as well, very famous speakers to talk to our webinars as well.
Yes, and for Babak, you can, I just answer your questions, and please send an email to jason.feng@aohua.com, and you will have the record of the webinar. And then,
Yes, and there
yeah.
is also a request about the colonoscopy webinar. Please send it to the participants as well.
Yes, and normally all the attendees will receive the webinar record And for other endoscopy users, they will need to wait for a long time, maybe half a year to, and we will upload the record to our YouTube channel.
And it's only fair to send them the link for people that have attended. They should have the information
Yes.
that they have attended live. They should have the information before uploading it to the YouTube channel. And Nadeshka, yes, we will do the bronchoscopy as well. I can't wait for the bronchoscopy, for the bronchoscopic procedure as well. I love bronchoscopies. Okay. See you next month.
Yeah, maybe next year.
Maybe next year. Yes.
Yeah.
See you next year as well. Goodbye, everyone.
Bye, Dr.
Goodbye.
Vasiki.
Thank you. Thank you.
Have a nice holiday.
Goodbye. You too. And everyone.